Yeah. And I did slightly shorten it to only GME as I was putting things together. I was like, there's not enough time to do
I
to
don't
do
think I don't think anyone will mind. I think it's going to be
yeah.
fantastic.
Let me just make sure they move forward. Yeah. Okay.
So we'll wait a few more minutes for more people to show up.
Sounds good.
But we usually have a good turnout, so it's exciting. I thought you were so fun when you're like, do you want just me or everybody on the updates? I was like, I just want you. You need this. Everyone needs it for their CVs. You know what I mean?
I appreciate the
Yeah.
invitation.
I was like, even the clinician educators need a grand rounds on their, whatchamacall. So that's why I was like, you're on the list. We're doing you.
Thanks. If you guys have anyone who needs to give things, I know Rachel is very involved in putting together, she's like coordinating the grand rounds for Penn. So just hit Rachel
Oh,
Miller up if
yeah, yeah, yeah.
there's,
I know
yeah,
Rachel. She's awesome. I'll hit her
yeah,
up then. That's a good idea.
yeah.
That is fantastic. You guys are still doing it virtually, I'm guessing, right? Or are you guys doing it in
Yeah,
person? Okay.
we still have virtual option, although this week for the first time since we just restarted our grand rounds last week. We did have the fellows and I met with the fellows in person and we watched it together before our didactics, which was nice. So
That's
I
nice.
think
Yeah, yeah,
maybe some
yeah.
people who are around might like come by to so we at least like a group of us could watch
The
it in
kind of
person.
camaraderie. Yeah, yeah.
Yeah.
Yeah, so our Department of Medicine ones are now in person or
Yeah.
hybrid. But then we just kept ours virtual because it's just so much easier for even the speakers. You know what I
Yeah.
mean? Like you
Well,
could
and
just go from
everyone's
one.
always at like a million different sites for their clinical work too. So,
Yes, yes.
yeah.
Okay, so I think we've got a quorum, so I'm going to introduce you if that sounds
Okay.
good to you.
Yes.
Hello, everybody, and welcome to the Division of Geriatrics Grand Rounds here at Northwestern in Chicago, Illinois. And I am delighted beyond all terms to introduce Dr. Eva Zamanski, who is a fantastic individual. And I've met her and spent so much time with her at SGIM. She is Assistant Professor of Clinical Medicine in the Division of Geriatrics at the University of Pennsylvania Perelman School of Medicine, and her clinical research focuses on strengthening geriatrics teaching and improving SmartPhrases to support geriatrics. I'm very excited also to hear that she is the new Associate Program Director for the Penn Program for Fellowship, and I am excited to introduce her and looking forward to this talk. So yay!
Thank you so much for having me. So I'm going to be talking about making little G geriatricians, which hopefully all of us can get behind. Um, and I wanted to start with just a brief story. One of my clinic patients has moderate dementia and definitely cannot remember or coordinate anything with his own medical care. But he has pretty good social cognition. And one time he was admitted with a heart failure exacerbation, and I was reading the notes, and the hospitalist note said, per PCP, patient has moderate dementia, but he's ANO times three here, and they were getting ready to like send him home and discharge him without talking to any of his family members about the care plan or making sure that they knew that he was coming home. And I think we've all encountered situations like this where geriatric syndromes and principles are not recognized by non-geriatricians caring for older adults, even though we all care for older adults and there's not enough geriatricians to go around. So it's so important for non-geriatricians to have some core skills in geriatrics. And that's really what's kind of driving my interest that Dr. Lindquist brought up. And what I'm going to do to kind of talk through that in broad strokes is talk through our internal medicine geriatrics curriculum and various innovations that we have been trying to implement to enhance making little G geriatricians. We've actually done like a program evaluation survey as well, so I'll talk about some of that. And then I'm hoping that just throughout this, there might be some ideas that come up of things you can incorporate into your own settings. Before I get going, I can't talk about any of this without also crediting Dr. Jessica Zuo, who's my partner in crime. We're both co-directors of the internal medicine geriatrics curriculum. So we do all this work together. And then some of you may know Rachel Miller as well, who's an amazing geriatrician educator who started this curriculum and is a huge mentor to us and still very much involved. I assume we're all like familiar with the geriatric 5Ms, but just to be 1,000% sure, they are up there if you need the refresher. And one thing that I wanted to point out with this is that they're so helpful for framing geriatrics education. And we've really tried to map everything in our internal medicine residency curriculum to the 5Ms and tried to use it as kind of a reinforcing concept throughout kind of all of our sessions. The QR code, it does pull up to a Google Drive. I know a lot of different institutions have been blocking various websites. So if any of the QR codes don't work, I'm happy to send links afterwards, but it just kind of shows our curricular content and how we've mapped it to the 5Ms. So I wanted to walk through kind of three main components throughout our residency curriculum that we try to create educational experiences in geriatrics, which are the clinical site, community sites, and then didactic experiences. In the clinical realm, we're going to talk about kind of these three components, and I'm going to start by talking about our ACE unit, which is where we have our smart phrase. The ACE unit, as I'm sure you guys are aware of, acute care for elderly, that we are fortunate to have one at Penn, and this is a standard rotation for all of our PGY2s in internal medicine as well as family medicine. This is staffed by Geri attendings and Geri fellows, and we've got a great interdisciplinary geriatrics team with a lot of interprofessional colleagues who also have geriatric certifications. We do routine didactics on the ACE unit on geriatrics topics, and then have been in the last couple of years working in more kind of standardized rotation specific teaching that doesn't depend on which attending is on, particularly with our interdisciplinary colleagues. So now every block, PT and OT give a talk, SLP gives a talk, and wound care gives a talk. So that's been really helpful for kind of like helping our residents understand better how the geriatric principles kind of overlap with some of those disciplines. And then the geriatric assessment smart phrase is also something that we have integrated into our ACE rotation. So this was kind of a more recent innovation that I was involved in that I wanted to highlight for everyone. We did fortunately publish this in JAGS last year, so there's a link to the article on that. But you can see this is kind of the template for our smart phrase. Again, we've tried to reinforce the 5Ms here, organizing it by those things. We have a couple of key questions for each category that are available right up front, and then additional drop-down menus that can be used. For the purposes of our inpatient ACE rotation, we try to encourage people to use this in the HPI when they're first admitting a patient to kind of get some of this background information, especially with cognitive baseline and functional baseline. And then kind of depending on what's going on, if there's a geriatric syndrome they're being admitted to, kind of flushing it out even further. And then we did study this both in inpatient settings, including on the Penn ACE unit as well as Yale's ACE unit, and then an outpatient setting at Cornell as well, of people using this smart phrase or slight variations. So I wanted to show you some of that data. This was before use of the smart phrase on the rotation, and after use of the smart phrase, we can see that residents and trainees who used this had increased comfort with the components of a geriatric assessment, with performing a geriatric assessment, and feeling like they had a framework for a geriatric assessment that were all kind of significant improvements. And then we also asked them if they felt like this had any impact on their clinical practice, and a number of them did, as you can see, especially with areas around delirium and cognitive impairment, as well as advanced care planning, working with teamwork, working with interdisciplinary teams, and working on discharging. When we looked at kind of the free response answers, when we asked trainees as well as faculty and fellows who were involved in the pilot study with the smart phrase, both groups felt like the smart phrase helped facilitate performing a geriatric assessment and kind of emphasized the 5Ms framework for geriatric specific care, in addition to facilitating learning about geriatrics. Of course, everything also has challenges. So there were notes from both groups about challenges in terms of impact on workflow, the smart phrase not being inconsistent, not being like consistently used or completed, and kind of need for ongoing education and integration of the smart phrase. So with these findings, we did feel like the smart phrase is an effective educational tool for geriatric principals. And kind of coming away from both our personal experiences as well as the comments from the study that we did, a couple of key tips that we have if you're looking to incorporate some kind of smart phrase as an educational tool is really trying to integrate it with the rotation curriculum. Every time I'm on ACE and kind of introducing the smart phrase, it is actually great now. It's become like very much routinely integrated where people just automatically are using it and kind of passing along to their colleagues that this needs to be used on this rotation. Um, but I think we all know, getting a template of something to fill out doesn't necessarily mean you fully understand like what it is you're asking and what's important from it. So I always try to incorporate a teaching on geriatric assessment and how it's relevant in our setting. So integrating that with the curriculum. Smart phrases, I think, and using kind of these templates as educational tools very much should be tailored to the needs of your site. Like I mentioned, the smart phrase that was used at Yale was actually a little bit had the same components, but slightly different based off of their local needs. With those comments on workflow, it's important to kind of anticipate what's the impact on my workflow going to be and how can I try to mitigate that. And then the other thing, again, kind of linking back with, you can't just give someone a template and say you're going to learn this just by using the template. It's really important for faculty to have buy-in on how you would like the template to be used, reinforcing that use, and then also kind of help guiding the trainees on what information they could be getting out of it and how to kind of continue to learn from it and adjust their practice using it. So the next big component I wanted to talk about from our clinical experiences is our electives. So we have really been trying to bolster our geriatrics electives to try to create little G geriatricians. We're lucky that the internal medicine residency actually, outside of us had decided in the past year or so to really increase the amount of elective time that residents get. And so we wanted to really like beef up our geriatrics options. Um, so we do have an outpatient geriatrics elective where is focused on folks who want to learn about those principles kind of more in the outpatient setting, learning about different sites of care and how to manage geriatric syndromes in the outpatient setting. So here with this elective, we always try to tailor it a little bit towards the resident's specific interest, but generally they'll rotate through our geriatrics primary care clinic, our outpatient consult clinics, our house calls team, our nursing home teams. And then we're also, any resident can pick to do this, but we're lucky that with our primary care residents, we've actually been able to make it kind of a requirement that they do a version of this elective during their outpatient PGY2 or 3 time. And then one thing that we've newly introduced in the past year or so, again, is the elective time went up and we're trying to really target what are the needs of our trainees and how can we kind of like pair the geriatrics aspect with what people's interest is we've created a geriatrics for the future hospitalist elective. A decent chunk of our internal medicine residency class ends up going into hospital medicine, whether for like their long-term career or kind of a bridge while they're considering fellowship. So we launched an elective that was kind of more focused on those folks and what might be helpful for them. So here the focus is more on inpatient geriatric syndromes, geriatric pre-op evaluations, and transitions for older patients. We're very lucky we have a good, robust, like inpatient geriatrics consult and co-management service at one of our hospitals that the residents rotate through on this elective. And then we also still have them go see the relevant outpatient sites too, for the kind of transition components. And there is a new hospitalist or hospital medicine track that's just being launched in the residency. So we're trying to work with them to get this as one of their like featured recommended electives. Again, I think one of the things for making little G geriatricians is really trying to like pair and collaborate with, with people wherever you can and try to meet with other needs and desires within the group. And I wanted to share kind of another innovation related to this, our electives. We did put together a Padlet. I'm not sure if you've heard of that website before, but it's a nice way to kind of collate a number of different resources and articles. Full credit, I don't know if you've uh, read Andrea Schwartz's work, but I got the inspiration for making a Padlet kind of based off of one that she had for their rotations. And so we send this to all our trainees, both residents as well as medical students who rotate through us with elective. And you can see we've organized this by the 5 M's and have a couple of like key articles and resources like Jerry Kit and like brief narrative articles in the Start Here section. And then there's kind of key articles that we've curated for some of the other M's as well that people will have available throughout the rotation. All right, so that's kind of what we're doing with our electives, trying to make little G geriatricians. The other thing that we have as part of our clinical experience is the longitudinal clinics. So we do have a primary care track at our residency, and then separate from the IM residency, we also do have a family medicine residency. And both of these groups have longitudinal outpatient geriatrics experiences. The primary care residents all have to pick a second longitudinal clinic as part of their second and third years. And so geriatrics is an option. Here they'll do 1 year with an outpatient geri clinic and then 1 year of house calls with one of our geriatricians. This has been great for recruiting into our fellowship, like getting people who might be vaguely interested and then they see what the care can be like and they get a chance to work with us. And we've had a lot of people then go on to fellowship based off of that. I was actually a primary care resident and did a second clinic with Rachel Miller and then obviously went into fellowship. Um, and then in family medicine, all of their residents who are part of their community medicine track do a year of longitudinal nursing home care with one of our faculty members, so they get exposed to that site. And then they also have the opportunity to do a year that's a mix of geriatric clinic and house calls. So this is another way. Again, I actually just met a resident who I'm working with on service now who's wants to do full scope family medicine, but really loves taking care of older patients. Probably is not going to do a fellowship, but she's getting a lot out of her longitudinal nursing home experience. So helping them get into that site. All right, so the next big bucket that we try to incorporate into our curriculum for the residents to bolster our little G geriatricians is trying to get people into the community. So we've done that kind of in these 3 main ways. Um, we have every internal medicine resident intern go on a half-day sniff visit where the goal is for them to see what that site looks like and kind of understand how complex a discharge can be from the hospital to the sniff. So we schedule them to spend a half a day with one of our faculty at the sniff, kind of get a tour and review documentation from a recent hospital discharge. And then as part of our didactic curriculum, there's a transitions of care lecture where we reflect on that experience as well as provide some other content. We also have all of our internal medicine interns go on a skilled home visit with one of our colleagues from Penn Medicine at Home, which is the skilled home care kind of through our institution. And this again is to really help with exposing, seeing what it's actually like in the home and exposing to the complexities related in a transition, as well as just kind of how to take care of people in the community. So on this one, they're assigned to be with a skilled home nurse, physical therapist, occupational therapist, or social worker, and they go out on visits with them for a half a day. We do provide them kind of a handout on the 5 M's and social and structural determinants of health as it relates to that to kind of help guide their observations. And we have them submit a written reflection And then as part of the didactic component, we have a group debrief and talk through kind of relevant home and community resources. Associated with that, we've also kind of put together a smart phrase that's more informational rather than like a template for part of clinical care, but a smart phrase as kind of like a just-in-time tool for them to be able to access key things like how to refer to skilled home services, how to refer to house calls program, how to get in touch with the pharmacy to set up blister packing, like how to get in touch with our local area agency on aging if someone needs equipment and things like that, that can be, again, that just-in-time tool for them to kind of link, this experience to their future care. And we always get really nice comments from the reflections. I just wanted to share a few of those, like excerpts from them. So one resident said, I think after this experience, I can be more clear in describing to my patients what home physical therapy actually looks like. Another one said, it made me realize how important it is for us to document good discharge plans for the home nurses to work off of to continue to reinforce those to patients. And another one said, this is yet another reminder of how social and structural determinants of health affect our patient population's daily lives in the context of, working with a social worker in the home on kind of a complex case with a patient. The third big bucket for getting people into the community is we have a part of our curriculum that's a senior center talks. So this had actually been going on before COVID and had been started by Rachel Miller. The original publication was down in the bottom there in 2017. And then unfortunately, with COVID had kind of fallen to the wayside. So we're trying to revive it this year and give it like an extra little innovative spin where, the primary goal being to, communicate age-related health topics in patient-friendly language, to the seniors at the senior center. With a secondary goal now is trying to incorporate some AI, which I know can be controversial, but another one of our residents had recently done a survey of the residency program that they were really wanting more formal education on how to use AI in their professional lives. And so this is another way where we've kind of tried to like sneak geriatrics together with other uh, like areas of interest and goals that the residents and the residency program has to try to kind of kill two birds with one stone and get them geriatrics principles as they're also learning these other principles. So we're actually just starting the first visits in the next week or so, but they'll get a guide on AI prompt engineering that we put together. And then we're going to ask them to use AI to help generate an outline and a handout for their community talk on an aging related topic. They'll visit a local senior center, give the talk, interact with the residents, get a very brief tour of the center, and then we'll have them fill out a follow-up survey and reflection, and we're going to have everyone kind of share the AI prompts that they used and the handouts that they created with that for kind of like group education as well. So we'll see how that goes, but that's a new kind of innovation we're going to try this year. The third big bucket is our scheduled didactics. So I'm just looking at the time. I'm gonna try to stay on with all of this. Um, so we're very lucky to have a lot of didactic time throughout all 3 of our years, especially more robust in the primary care track. You can kind of see the topics that we cover with our didactic cycles. The star that I put up there on transitions of care and community resources, those are ones where we're sharing that smart phrase along with them. So they can go back and refer to those Geri community resources when they need to. And then the other big thing as part of this is we've really been trying to enhance our presence at noon conference. So this is another way, they're always looking for noon conference speakers in our institution. There's like 3 different sites where the residents are rotating. So we're just like really trying to be proactive of like volunteering ourselves. Do you need us? Can we do a Geri talk? Can we be a case discussant? So that's been a great way to try to enhance our presence and sneak in some geriatric principles into their general rotations. And then the other thing that we've done here, again, is trying to align with other specialties. So one of the talks we do for the interns is actually technically during renal's didactic time during their capstone. But we have a shared session with them on clinical reasoning and multimorbidity, which the clinical part is kind of like hypertension management and advancing CKD, like renal themed, but we get a chance to do a geriatrics talk on how to look at the evidence as it relates to older adults, how to assess our patient, and then how to kind of combine all of that as we're thinking about clinical management. So the whole capstone session is very much both renal and geri, which is a nice way for us to use someone else's time that's in the didactic curriculum, but get our principles across as well. And then this isn't really part of our medicine residency curriculum, but just to say this is another new thing that we've been doing since we received a GWEP. We've partnered with the Curbsiders to make kind of a Gericiders mini series, and we're helping produce episodes that are geriatrics themed. So this is the link if you want to see what's been produced, and there are more to come. And if you have any ideas, feel free to reach out for either speakers or topics. So this is another good way to kind of refer our learners, because some people really like listening to podcasts, referring them to that and getting some principles there as well. Okay, so I'm going to try to, please just stop me if we need to end early. I know it's like 45 minutes or slotted, but I wanted to briefly share some information from our curriculum evaluation before I wrap up. So we recently completed a survey both of current residents and of recent graduates from the past about 7 or so years since we've been doing this geriatrics curriculum and kind of assessing what are their skills on geriatrics topics. So we got about a 50% response rate for the residents. We have a lot of mostly categorical residents who want to go into subspecialty non-geriatrics practice. For recent graduates, it was also about a 50% response rate, again, seeing most of them were categorical, and a pretty decent split of, how long ago they graduated. Most of them are in subspecialty practice or hospitalist primary care, and the majority of them have a decent chunk of their patients who are older adults in their current job. So the main thing that we did was ask them how, please self-assess how well you can perform these various skills in your clinical care of older adults. I'm not going to belabor every single one, but you can see we kind of took things based off of the 5 M's and kind of tried to get what are key geriatric principles that like everyone should have some skill in doing. And so this is looking at the current residents. Again, don't want to necessarily dwell on the details, but just kind of looking broad strokes. This is broken down by folks who are in the primary care track versus not in the primary care track. And you can see that there are a number of topics where the primary care track residents are a bit more rated themselves as higher skilled in that topic. But overall, most of the numbers are like relatively low. These are the percentages of people who said that they did very well or extremely well with that geriatric skill. So we don't have a lot of topics where people are passing the half of them think they're doing very well or extremely well on the topic, with a little bit of variation between the primary care and non-primary care. And then this was pretty similar when we looked at the recent graduates as well and their self-rated skill. Again, the primary care track seemed like maybe a little bit more comfortable with some of the topics. And the topics that people are more comfortable with are pretty similar for the graduates versus the current residents. People tended to be more comfortable with like delirium recognition, incorporating patient goals, and then kind of less comfortable with things like geriatric assessment, dementia management and evaluation, and things like that. And you can still see the numbers are like relatively on the lower end in general. When we look at kind of over time, again, this is more just to see trends rather than looking specifically which color is which thing, but just comparing from all the way over to the left, we have our PGY1s who were surveyed before they got any curriculum. So this is kind of like baseline coming into residency. The people who are PGY2 and higher are kind of the people who are getting the curriculum. And then the recent graduates obviously have received it. And you can see that, when they're getting the curriculum slash, they're obviously the confounder of like going through residency. They have increased skill in most of these things that then kind of tapers off in the recent graduates. And some of them might stay a little bit, like the grads are still feel like they're better than the PGY than they would have been PGY1, but there's others where they get basically back to the same baseline. And then if we look at just the recent graduates and kind of seeing going within those who graduated in the past year versus like through those who graduated 5+ years ago, again, there's kind of some topics where there is an attenuation where you can see over time they rate themselves as less experienced with the skill, whereas others that stay a little bit flat and a couple that might go a little bit higher as they're in practice. Obviously, I think when you're thinking about recent graduates, there's kind of the confounder of maybe people, now that they're in practice by themselves, maybe they actually like have the same skill that they did in residency, but they realize how like that they need even more than that. So that might be kind of a confounder as we're looking into this as well. So we also asked them about what's going well. They mentioned things with lots of touch points with our faculty, various sites, and multidisciplinary experiences, as well as good repetition. Um, and then we asked them if they had any other thoughts for improvement as well. And you can see some of these concepts. They're looking for things that are more actionable, things that are more relevant to their subspecialty lives, and maybe some more opportunities in outpatient. So this is very much like a quick look. We've only just started looking at all this data and have to like parse it out even more, but some kind of key things that we're thinking of looking at some of our survey data for our geriatrics curriculum and residency. It definitely seems like there's some topics that stay with low skill levels that we need to try to enhance. It sounds like people are wanting more enhancement of topics that might be related to their subspecialty lives, and then kind of thinking about, that drop off that we saw, for the recent graduates, thinking about how can we help maintain skill with time. So a lot for us to kind of ponder as we're iterating on our curriculum and making these little G geriatricians. So I wanted to kind of just wrap up with some thoughts after the whirlwind tour through our IM residency curriculum, various education innovations that we're trying to work into it. I think some key things that are becoming more apparent to us are the importance of having a consistent framework throughout to guide both us as well as for our learners to use. So the 5Ms are excellent for that. Really repetition of topics over the different years, over different sites of care, just getting it into people multiple times. I think anytime you're able to pair an experience with not just a didactic, but actually getting into the site, getting into the community, working with our faculty, we've tried to incorporate that as much as we can. Trying to use this concept of stealth geriatrics that I found mentioned in an abstract that someone kind of created that term, that's basically like trying to sneak in geriatric content with other things that are already in the curriculum that maybe necessarily weren't geriatrics themed but could be. So kind of like what we're trying to do with our renal and geri joint session, looking for those opportunities, especially since these curricula are always so crowded and so many different things that need to be covered. Really trying to target towards the goal of the trainees, which we've tried to do with our hospitalist elective and our other flexibility that we have with our electives, and then trying to provide some just-in-time educational tools, whether that's a smart phrase to help with actually learning geriatric principles and applying them, like the 5M smart phrase, or other kind of more resource-based tools, or the Padlet that people can kind of have references to go back to easily. So those are kind of some key lessons that we've learned for our journey of making little G geriatricians. And I just wanted to wrap up and see if you all had any thoughts about how any of this might apply to your own lives. I know geriatricians always have their hands in many different buckets, so I'm sure some of you are on UME, some of you are on GME. Just wondering if any of this sparked anything. Hopefully it did, and I'm always happy to talk through things if it would be helpful. And thank you so much for your time.
Yay, that was an outstanding talk. That was fantastic. I really enjoyed it, Dr. Zamanski.
Yeah.
So I'll open it up for questions or comments. If anyone wants to talk.
Eva, thank you for the great talk. Sarah Bradley, can you go back to that last slide that you had up? Because I just think that is such a great summary of all the stuff, right? Because it's just like, not just one thing, it's like all these things. And I think you just made so many good points here, getting the stealth geriatrics, right? So they need you to teach something else, put some geriatrics. Yeah, we'll teach that for you, but we're also gonna put some geriatrics in. I think like anytime you can do that is good. Targeting to trainee goals, we know like Penn has the same problem we have. A lot of people are going into specialties. Well, let's teach them some geriatrics so they can apply it in their specialty. And then I think just getting the curricular time is always tough. But anytime you can get the trainees to your sites and communities is awesome. So it seems like you guys have a good amount of curricular time with the ACE unit and other things, and it sounds like you've made it a great experience for them, and that's why you've gotten that time. So congratulations to you.
Thanks.
And Rachel showed us that Padlet before, I think, and Jen already texted me. We're gonna steal it probably. So thank you.
Please do. Please feel free to if there's any other key articles that you guys love that you think should be added, just send me an email. We'll pop them on.
Yeah, it's great. Thank you.
Yeah, I was just going to echo that. I thought this was fantastic. Thank you for what you're doing. And I loved the website. I opened it up and was just glancing through it, the Padlet. Is that a free resource or do you have it through your institution or?
We don't have it through our institution. Actually, the issue we're having now is that our institution Wi-Fi has really been cracking down, and now we're having trouble accessing Padlet on our institution Wi-Fi. But it is not, it's free to anyone. You can make a free account. I think there's just a limit of how many boards you can create with a free account. And so that's just one that, I made a free account and put it up on there. And you're welcome, absolutely welcome to take it.
Awesome. Thank you.
Yeah.
I loved it.
Yeah, I love you using the stealth geriatrics, even though you borrowed it from somebody. I still love it. I'm like, so I might be borrowing it from you. You know what I mean? Just to keep it going.
The only thing I found in terms of actual publications was a couple of abstracts of this group. I forget. I think they might have been out of Minnesota. I don't know any of their names, but I would love to connect with them. I feel like it's a great. I mean, one, it's a catchy phrase, but it's absolutely, as a number of you were saying, what we need to be doing, with a field like geriatrics that's really relevant to everyone, but that we have trouble getting enough curricular time for ourselves. We just really need to align and sneak it in where we can.
Hey, quick question. How big is your ACE service? How many patients do you have on your ACE service?
We have 20.
Okay.
Yeah, 20 patients. We've had a lot of iterations of how the resident structure is because there were some complaints of not liking the rotation because of kind of more the structure. It was a Q28 structure initially, actually. But they've recently made some adjustments, and I think it's been much better for the residents to really have time to be able to engage with family communication, detailed disposition planning, more kind of teaching on geriatric syndromes as they relate to admitted older adults. So I think it's been really great, and some of the changes have been well received from the residents.
No, that's fantastic. I love it. I wish we had an ACE.
Yeah, it's really nice. It's very nice for, both from a practice standpoint as well as from an educational standpoint for people.
Awesome. So if there's any other questions, feel free to ask. I'll pause for a few minutes, but I'm sure I echo everybody on this call that we just really loved your projects and we think you're fantastic. And I actually look forward to collaborating with you down the road on stuff. And I'm sure my team is very excited about what you're doing as well. So thank you so much, Dr. Zamanski. You're fantastic.
Thank you again so much for inviting me, for being such a welcoming group. Like I said, feel free to reach out anytime. Although, as I was mentioning beforehand, I am going to be out on maternity leave from like November to February-ish. But Jessica, my partner in crime, is absolutely available. We'd love to connect with anyone.
Yeah, and congratulations. This is
Thanks.
exciting.
Thanks.
Yeah.
Thank you.
Okay. Thank you
All right.
guys. Have a good week.